Now it is a pleasure to introduce the last speaker from United States of America, Professor Dr. Paul Whelton, who will speak about optimal target for systolic pressure during antihypertensive treatment. Professor Paul Whelton.
Hello, everyone. Wonderful to be with you. This is Dr. Paul Whelton. I'm the Whelton Chair in Global Public Health at Tulane University in New Orleans in the U.S. And I'm the immediate past president of the World Hypertension League. Today, I want to talk about optimal targets for systolic blood pressure during antihypertensive therapy, and I have no conflicts of interest. So, by way of background, clinical trials obviously have demonstrated that blood pressure lowering reduces cardiovascular risk and mortality. But there's no universal agreement on the optimal treatment target for systolic blood pressure in adults when we're treating patients. There's a certain amount of variety in the major English language clinical practice guidelines. Now, all the guidelines agree we should at least get to a systolic less than 140. That's a given. The uncertainty is really when we get to lower targets, less than 130 or less than 120. And guidelines vary from being the most to the least conservative. The most conservative English language guideline is the Family Practice Guideline in the US. It says less than 140 in most adults. They would say in adults who with hypertension who've had a stroke or TIA, 135 is appropriate. Other guidelines you can see here, they vary. And the most recent guideline is the European Society of Cardiology. They would say 120 to 129 is the appropriate range, but they encourage getting down to 120 if that's possible. Most of the guidelines recommend a lower target for those who have underlying high risk of cardiovascular disease. In the Australian and the Canadian guidelines, that's less than 120. Now, in clinical practice, almost everyone that you're going to see is at high risk. They almost all have additional risk factors, so it would be extremely unusual in a typical adult clinical practice to see patients who are not at high risk. Now, in terms of the underlying science, there have been tons of meta-analysis and individual trials, and there have been several group and individual participant data meta-analysis. They've all suggested that lower targets are better than higher targets. And I'm just showing one example here. This is the most powerful statistical meta-analysis, a network meta-analysis that our group did. And basically it shows that the treatment is the inverse of observational. So observational, from lower to higher pressure, you get increasing risk. With clinical trials, from higher targets to lower targets, you get decreasing risk. And of course, the biggest decrease will be for those who have the biggest decrement in blood pressure. But if you see down here, even 120, 124 versus 125, 129 shows a statistically significant difference. That's true for overall cardiovascular events. It's true for all the individual outcomes: stroke, heart attack, heart failure, etc. Now, so these are powerful meta-analysis. One caveat is that they look at blood pressure differences in three different ways. They take trials that have compared drug versus placebo, more versus less intensive therapy, and randomization to different blood pressures. Obviously, the best of these would be randomization to different blood pressures. These would be the, if you will, the gold standard trials. So we felt there was a need to do a meta-analysis that restricted the analysis to these types of trials, and we felt there were enough of these types of trials to make a meta-analysis meaningful. And so we specified trials that had a target in the more intensive group of less than 130 versus higher, and we looked for trials that had less than 120 versus a higher pressure. That was the basis for our meta-analysis. You can see here on the left-hand panel the sort of flow diagram. So we found at the time we published the meta-analysis 7 trials less than 130 versus 130 or higher, and 4 trials less than 120. They were all less than 120 versus less than 140, so all sprint-like trials. There's been one additional trial since that time, and I'll talk about that later. We developed a protocol, registered it with Prospero. We searched the literature. We extracted the data. The primary analysis was less than 130 versus a higher target pressure. The secondary analysis was less than 120 versus less than 140. All the trials really were of high quality when it came to the major outcomes of interest, blood pressure and cardiovascular outcomes. The mean difference in systolic blood pressure was substantial in almost all of the trials, more than 10 millimeters of mercury in 6 of the 7 trials. There was a low Cochrane risk of bias for all of the trials, and there was no evidence of publication bias. On the other hand, when it came to adverse events, these were not collected very carefully, and they were pretty inconsistent, and I would say of poor quality. We did 3 sensitivity analysis that I'll talk about in a moment. So let's cut to the chase. Here we're looking at major cardiovascular events as the outcome, and we're looking at, in the top panel here, less than 130 versus 130 or higher trials. Here is the line of identity, and everything to the left here would suggest more intensive treatment is beneficial. And you can see all the trials tend to shift to the left here. It's very obvious. And when you pool them, it's highly statistically significant, and the confidence interval is quite tight. Looking at the less than 120 versus less than 140, there are obviously less trials, but again, they tend to be shifted to the left. It's pretty obvious visually, and the pooled analysis is quite significant, and the confidence interval is relatively tight, even though there are only 4 trials. So very strong evidence for benefit in terms of major cardiovascular events. Now, looking at all-cause mortality is an outcome that we don't usually have as a primary outcome, but it's very striking. It's not only a powerful clinical outcome when it occurs, but statistically it's very powerful because there's virtually no bias when you look at, there's no possibility for bias when you look at all-cause mortality. In trials, we know with virtual certainty 100% of the time whether somebody is alive or dead. We may not know why they died, but we know whether they're alive or dead. And so there's no possibility for bias. Now, looking at the less, for this outcome, looking at the less than 130 versus higher targets, there's in most of the trials a shift to the left, and it just meets statistical significance. For the 120s, it again tends to shift to the left. It just misses for this analysis the statistical significance. I should say that all of these analyses are done using what's called a random effects model. That's a very conservative model that makes no assumptions about the trials. It doesn't assume they're showing the same benefit, the same results in every trial. So pretty convincing for all-cause mortality, very convincing for cardiovascular outcomes. When we looked at the individual cardiovascular outcomes, stroke, coronary heart disease, heart failure, cardiovascular mortality, for both the less than 130 trials and the less than 120 trials, it was nominally significant and substantial reductions in the hazard ratio for both of these, so pretty convincing. Looking at adverse events, again, I would say the caveat that they were not collected very carefully, but there did seem to be some adverse events. The ones that seemed to be nominally significant were hypotension in the more intensively treated group, hypotension, syncope, injurious falls, electrolyte abnormalities, and reports of acute kidney injury or acute renal failure. Having said that, they were pretty infrequent for both of the groups of trials. For instance, for hypotension, we estimated that you would need to treat over 500 patients to see one report of hypotension. You would need to treat almost 2,000 people to see a report of syncope, and even higher for the other outcomes, and the same over here. So they were there, but they were not very common. As I mentioned, we did 3 sensitivity analysis. We took one trial out of the 130 comparison because it was a it was a group trial. It had virtually no effect on the best estimate or the confidence interval. We excluded the 4 trials that were less than 120 from the 130 comparisons. And again, we saw a similar trend for the remaining trials, but obviously we lost significance. We used a fixed effect model, which is not unreasonable here. The fixed effect model assumes that all of the trials get the same relative effect. It had very little effect on the hazard ratio. As you might expect, it tightened up all the confidence intervals. As a consequence, the confidence intervals were statistically significant for both the cardiovascular outcome and for all-cause mortality for the 120 versus 140 trials. So there's been one trial that's been published since that time, BP Road. This is a big trial that you're probably familiar with. It was done in almost 13,000 Chinese adults with hypertension who had diabetes as well, and of course had high risk for cardiovascular disease. And the primary composite was, again, primary outcome was a composite, very typical cardiovascular composite that assumes atherosclerosis as the common denominator. They got good blood pressure differences during the 4 years of follow-up, and the primary outcome was highly significant, with a hazard ratio of 0.79 and a very substantial p-value. Now, when we added that in, the hazard ratios were unchanged for both analyses, but there was significance for cardiovascular disease, all-cause mortality for both of the comparisons, the 130 versus higher and the 120 versus 140, using either the random effects model or the fixed effects model. So I think with this trial now, there's even more compelling evidence of benefit for getting to these lower pressures. So in summary, for our primary analysis, the less than 130 versus higher pressures, there was very strong evidence for cardiovascular benefit and all-cause mortality based on results now from 8 trials. There are 2 trials that are going to be coming in from Brazil that I'm involved with. They're called optimal blood pressure trials, one in diabetics and one in stroke survivors. And they'll come in another year or so, and they will add additional evidence. For the 120s versus 150, a smaller number of trials, 5 trials, but again, strong evidence, significant benefit for both cardiovascular and all-cause mortality. There were adverse events, both hypertension, syncope, injuries, falls, electrolyte abnormalities, and acute kidney injury or acute renal failure reports. These are clinician reports now, not verified. However, they were infrequent, and you needed to treat a lot of people to see any of these outcomes. So on balance, the benefits were very important and much more common than the adverse events. As I mentioned, there are 2 trials that are yet to come in, and that will, I think, seal the deal. So the findings of this meta-analysis support more intensive treatment to lower blood pressure in adults with hypertension who are high risk for cardiovascular disease as long as it's tolerated. And of course, this would be most patients in clinical practice. So again, always a pleasure to be with my colleagues from Egypt. And my only sadness is that I'm not with you in person, but I hope I'll see many of you at the American Heart meetings here in New Orleans in November. And I will remind you that the update of the ACC-AHA US guidelines will be coming out and presented at the AHA Hypertension Council meetings in early September, and we'll be addressing this issue of target for systolic blood pressure during treatment of antihypertensive therapy. Thank you again, as always, for inviting me to be a part of the meeting. Bye-bye.
Thank you, Paul. It has been a pleasure listening to you. Unfortunately, you were not able to join us in Cairo, so we are looking forward to see you in Cairo next year. Paul Whelton is an old friend of mine and of the Egyptian Hypertension Society. Now we will close this session and we will move to the opening ceremony.